Thank you, Mark, and the organizing committee. It's a beautiful venue. Thanks for giving me the opportunity to speak today. These are my disclosures. I'll be discussing some investigational devices in a PSIDE trial, as well as potentially off-label uses of commercially available devices. So over the past several decades, there's been a lot of advances in endovascular treatment of aortic aneurysms, especially dealing with more complex anatomy. However, with this complex anatomy, there's been development of new techniques necessary to deal with these patients. So since spring of 2012, fenestrated endovascular repair has been commercially available in the United States. And since that time, there have been other fenestrated or branch technologies available in trial, such as the Cook P branch, as well as the T branch device. With these devices and treatment of more complex aortic aneurysm anatomy, there also becomes a use of new adjunct techniques to help perform these cases. Preloaded wires are something that's available in the P branch device and has been utilized to allow earlier sheath access and hold a sheath in place to allow ease of visceral vessel cannulation during these cases. There have also been descriptions. This is a diagram from one of Dr. Odrich's from Mayo Clinic's use with physician-modified endografts, utilizing brachial access for having preloaded wires. And this is a physician-modified graft on the left of the screen. And as you move to the right, each of those branches is pre-wired and cannulated with a wire that's approached from the brachial. This allows easy deployment of the branches from the upper extremity. So Access Scallops is the ability of, is a use of a scallop, and this could be both in the Zenith fenestrated device to allow cannulation of the difficult visceral vessels or downward angled anatomy. And this could also be used in the Z-Fen device as well as the custom manufactured devices that are now available in IDE trials throughout the country and outside the United States. So what an access scallop is basically allows the plan of using the upper extremity to help cannulate these vessels. And it allows access to the vessels prior to fully opening the graft. This is an example of a patient with previously treated anatomy with an endograft with a type 1 endoleak who had a short neck. Here is some of the images. You can see that there's flow outside the graft. This device was treated with a custom manufactured device from Cook. This is the Access Scallop. It's a reinforced scallop with preloaded catheters, which are able to allow access from the upper extremity down into the visceral arteries. And in this case, two catheters were used to access. One was used for the celiac artery through a reinforced scallop, and the other one was through the right renal artery as well. Also of note, on the right, you'll see an inverted limb device, which is used to treat these patients with short main body grafts and has an inverted limb to be able to hold the device because there's not a lot of room in these patients. So this is a image after the device is in place. Wires are gone through the access scallop, and from the upper arm, a sheath will be placed in the descending thoracic aorta, and the wire will be captured and snared. There you have it, snared, and there are two. You could do one at a time. Following that, the top arrow demonstrates the access scallop. The bottom arrow demonstrates the fenestration of the celiac artery. You could also see our fusion marks. And with the wire snared, you have a through and through access from the brachial access, from the contralateral groin, from the ipsilateral device. And then the graft could slowly be opened towards the area of the celiac or the first fenestration that you're dealing with. Following this, initially from the upper arm through the access scallop, the catheter could be placed in the endograft. Here the wire is in the SMA, but that will be easily redirected in the next slide. And you can see this is only partially deployed at this point. This allows full control and easy maneuverability to rotate the device, especially in a complex 4-vessel device such as this. Following this, the celiac artery is accessed from the arm, and a Rosen wire is typically placed in that. Then the rest of the device can be opened, and from the right renal artery, in this case, I skipped a few slides, was also able to be brought in through the access scallop and able to be cannulated with the catheter. And as you can see from the bottom of the screen, this device is still not fully deployed at this point. This is a completion CT scan showing a complete endovascular exclusion of the aneurysm, the 4-vessel fenestrated device. However, the use of these access scallops is not a cure for all bad anatomy for the fenestrated. This is a patient who is in his 70s with bad CHF, not a candidate for open endovascular repair. Of note, you can see that he does have an atrophic right kidney. In the patients like this, we do obtain nuclear medicine scans, and this one showed he only had 9% function of his right renal or right kidney. So we deferred to treat this right kidney. Of note, he had about 30 millimeters of seal from the fenestration of the left renal artery to the SMA. However, I made a scallop just in case, given the angulation of his anatomy. And you can see it lands right below in the top left corner, right below the SMA. Here's just the design of that, which was a single scallop I made, 6 millimeter high, just in case. However, it is noted that in patients who do have single vessel fenestration of the design, it is difficult sometimes to line up that scallop, especially in angulated anatomy such as this. So because this was difficult anatomy, I chose to pre-cannulate both the SMA and the left renal artery here. And you show good flow and lined up the graft based on the left renal artery. And I was able to deploy the graft very easily right on the left renal artery. However, to my dismay, the scallop did not line up with the SMA, and it turned me from the happy-go-lucky vascular surgeon to a popular meme that's currently going around with a former UNC graduate. Because of this, because I was wise enough to place a wire and a sheath in the SMA before this, I was able to bail myself out doing a chimney of the superior mesenteric artery. So we use scallops not just for access scallops. We use them, the most common derivation of the Cook Zenith fenestrated device is a 2 small vessel fenestrations for the renal arteries as well as a SMA scallop. We don't stent all of our scallops. We practice a selective stenting where we place a balloon, as you can see in this diagram, and place it in the SMA scallop and balloon it to see if the visceral segment moves. Other indications for stenting scallops are pre-existing visceral vessel stenosis as well as just one single fenestration. So there is more lined up anatomy as well as less mobility and chance of migration. So in conclusion, access scallops, preloaded wires, and preloaded catheters are useful adjuncts in treating difficult fenestrated aortic anatomy. Approach from the brachial or axillary access may help in downward angle vessels. And scallops are not, they're sort of backups, but they don't solve all problems in difficult fenestrated anatomy. Still, there are indications for different devices. Angles are, especially in the visceral segment of the aorta, are difficult problems to deal with, and they should be approached with caution in these patients. Thank you very much for your time.